This is infiltration of normal saline 50 cc's into the suprapatellar pouch so that we have a swollen knee where we can make a stab incision without damaging the structures underneath. We are now marking the ligamentum patelli, the lateral border of the ligamentum patelli, where it attaches to the lateral border of the patella, and in that notch is the bulge of the infrapatellar pouch. Now, there we feel a depression. That's the depression that you feel, and it is here that you will make a stab incision. So we take the knife, we make a stab incision, and as the fluid comes out, we know that we have punctured the synovium. The edge of the knife is directed away from the ligamentum patelli and directed away from the anterocruciate ligament till the knife touches the intercondylar notch. Then the skin incision is extended a little bit, and the capsular incision, we make a cruciate incision so that the base of the scope can be slided medially laterally. Now we put in a probe, we put in the trocar with a sharp probe till it hits the intercondylar notch. We remove the trocar, replace it with a blunt trocar, extend the knee and advance the probe into the suprapatellar pouch. Now, as we put in the arthroscope with the camera which has been wide balanced, there are these two probes that you see, one for the irrigation and the second for the suction. So we place the suction and irrigation, and you see that the scope is lying in the suprapatellar pouch. Then, since the light source is coming from below, it is looking up, and you are looking into the suprapatellar pouch, and you are seeing a plicae, which is the medial synovial plicae. Now you gradually pull the scope, you see some sort of fibrillations, and then you start seeing the patella. Scope looking up, gradually being withdrawn, and you can see the patella from the medial to the lateral. And our conclusion is that the articular cartilage is fibrillated at some places, but otherwise the patella is in a wonderful shape. Nothing to do about patella. Now we will move the scope directed downwards. That means the light source will come up. The light source has come up, and we'll move it across the femoral condyle into this gutter. The convexity that you see is the medial femoral condyle and the tibia. So there is the tibia, and that is the medial femoral condyle, and the synovial fold is coming from the meniscus. And we open the medial femoral condyle by flexing the knee, and now we can see the meniscus. We can always adjust the camera rotation, and we are now seeing the intercondylar notch, and we find that the meniscus is damn good. It is fine, and we need not do anything to the medial meniscus. What you see on the outer side, on the right side, is the margin of the anterior cruciate ligament. Now we'll look that it's attached properly to the intercondylar notch, of the tibia, but we will look at the upper attachment of the anterior cruciate ligament, and we'll find that there is a partial tear. It's not completely torn as reported in the MRI, but there is a partial tear in the intercondylar notch, which you can see there. So the medial compartment, the menisci, then move into the intercondylar notch, and you see the anterior cruciate ligament. Then you move into the lateral compartment, and you will start seeing the lateral meniscus. Since we are not able to open the lateral condyle sufficiently by a varus strain, we will put the knee into what is called as a figure of 4 position. So this is the lateral condyle. You can see a flounce on the border of the meniscus, and if you see this flounce, it suggests a tear. So this is another view of the medial meniscus, the anterior cruciate ligament. You are going right up to the anterior horn of the meniscus, then you are going to the cruciate ligament, ACL, see some evidence of a tear from its femoral attachment. So, putting a varus stress, we've opened the lateral compartment, and from the intercondylar notch we are looking at the posterior horn of the lateral meniscus. Now we'll go on tracing this margin, looking for a tear. There is a small radial tear that you see there, but obviously there is no bucket handle, and since there is no bucket handle, it is unlikely to lock the knee, and we'll treat such tears, small tears and small injuries, by enhanced growth factor injection post arthroscopy, rather than trying to do surgery on them. Now we have entered the popliteal recess. The popliteal recess is normal, and therefore our diagnosis is suprapatellar pouch normal, patella good, medial compartment good, medial meniscus okay, partial tear of the anterior cruciate ligament, and then a radial tear, 2 radial tears of the lateral meniscus, which are unlikely to lock. So no surgery is planned for these injuries. We'll wash the knee, and we'll give post-operative platelet-rich plasma, enhanced growth factor injection into the knee.